session number 3, Prescribing the Future of Antimicrobial Stewardship, Pharmacy and the Fight Against Resistance. And your speakers are Dr. Paul Bonnar and Dr. Emma Reid. Dr. Paul Bonnar completed his internal medicine and infectious diseases training at Dalhousie University. He then completed a clinical fellowship in antimicrobial stewardship at the University of Toronto. After
This
completing
is
this
the one I wanted.
Oh, sorry, please make sure you're muted. After completing this fellowship, Paul started his position as physician co-lead for the Nova Scotia Health Antimicrobial Stewardship Program in July of 2017. Dr. Emma Reid completed her Bachelor of Science in Pharmacy at Dalhousie University in 2013, followed by a hospital pharmacy residency through UBC in Vancouver. In 2019, she earned her Doctor of Pharmacy through the University of Alberta. Emma has cared for hospital inpatients for more than a decade and currently practices as a pharmacist with the Nova Scotia Health Antimicrobial Stewardship and Emerging and Re-emerging Infections program in Halifax. Over to you guys.
That's great. Thank you so much for the introductions, and thank you all for joining. So I'm Paul, and I'm going to start out the presentation, and then Emma and I are going to swap off a little bit. But very excited to present today. And we were asked to really give an overview of antimicrobial stewardship, and in particular highlight some of the technology that we use and the collaborations to date with infection prevention and control. So the objectives of our talk are, again, to review what antimicrobial stewardship is, and in particularly highlight antimicrobial resistance. Obviously, that's the major concern that we're trying to address with stewardship. And of course, IPAC plays into that too. So we'll go over some of that epidemiology. We'll highlight some of our local resources for antimicrobial stewardship or managing infections, some of which certainly can be relevant for infection prevention and control practitioners, and highlighting some of our technology that we've used to date. And then lastly, can I go through a few of our initiatives that have a particular IPAC, AMS, antimicrobial stewardship connection. And all of that really, happy to brainstorm around future endeavors and collaborations between our groups. So again, antimicrobial resistance, as I'm sure you are all aware, has certainly worsened over time. Really, I often think of pre-pandemic and post-pandemic, but over the last 10 years, things have worsened really across the globe. And we've seen that locally, of course, at least in Central Zone. I mean, the VRE alone highlights that trend. Lots of reasons for that, of course. But even more concerning is the gram-negative resistance. Again, something we've seen locally too, before the pandemic, if we saw a carbapenem-resistant bacteria, that caused a little bit of, anxious excitement. Now it's becoming, unfortunately, quite common, or shouldn't say common, I guess, but, it's certainly not rare, and it's something we see more and more of. And really, those gram-negative resistant bacteria is really what has a lot of us worried, because there's really very limited options to treat. On any given week, we have an inpatient that there's no commercially available drug that'll work for their infection available in Canada. There are agents available in the world, but we're getting into like last-ditch efforts here, and drugs of last resort. So this is a real problem. Only worsening with time, unfortunately. This is a infographic from WHO. Which has, highlighted antimicrobial resistance as one of the great global threats that we're facing now, and certainly will worsen if things don't change. So over the last, 6 years or so, from 2018 to 2023, a 40% increase in resistance, and expecting that to continue. In Canada, this is an older report now, just before the pandemic, but really meant to highlight the Canadian state of things. Often, I think we view ourselves as being a bit insulated. Certainly in the Maritimes, traditionally we were, but certainly not anymore. And even back in 2018, at least a quarter of our infections were resistant to first-line antimicrobials. That's undoubtedly worse now. We have second, third, fourth line agents, but often those are more expensive, more toxic, just don't work as well. A classic example would be vancomycin, right? So, MSSA, methicillin sensitive Staph aureus, we can use cefazolin and or cefalexin. Whereas MRSA, you need Vanco, which, as I'm sure many of you are aware, is a pretty nasty drug that doesn't work terribly well. And even then, at least 15 deaths per day directly attributed to antimicrobial resistance. Hard to measure that, of course, but undoubtedly morbidity and mortality is worsening due to trying to manage these very complicated infections. And by 2050, expecting at least 40% resistance to first-line agents, that's looking pretty realistic, at least 38 deaths per day due to antimicrobial resistance. So hard to project these things. It's that slow-moving disaster scenario that is hard to get much attention and therefore hard to address. All that added up, it's expected to be pretty expensive. I think it's about 400,000 deaths total by 2050, directly due to antimicrobial resistance. And again, all that's super expensive, as you can imagine. We'll be talking a lot about bacteria, but this does apply to other things. Thankfully, we haven't had much Candida auris. But even, non-auris candida, we see a decent amount of resistance. And there's even less antifungal agents available. And things like tuberculosis, gonorrhea, these things, while certainly TB is uncommon here, we see enough of it. And we have seen multi-drug resistant TB, which is even scarier. And then at the same time, we struggle with this issue where we're trying to preserve antibiotics, but we know at least 30% of the time antibiotics are being used unnecessarily. That can vary depending on the syndrome and setting you're looking at. For instance, upper respiratory tract infections, this number goes up to about 50% unnecessary, or certainly 50% could be optimized. Shorter duration, narrower agents, all those types of things. So that's really what we're trying to address, is that optimization of antimicrobials. And not only resistance is a direct consequence of overuse of antimicrobials, but as we use more antimicrobials, certainly when we use them unnecessarily, we're getting more adverse events that are harder to justify. So, these can be mild from, GI upset, but all the way up to things like C. difficile, which we've seen a fair bit of, to kidney injury, to cell count changes, to neurological effects. So we tend to quote this 20% number. That's based on inpatients in Johns Hopkins, but is a useful number to keep in mind when we're either counseling folks on whether they need an antibiotic or not, whether that's patients, families, or other practitioners. It's like, well, what's the benefit risk here? The benefit in a certain scenario may be quite low, like a sinus infection, but you're potentially exposing to a lot of the risks. So we do use this as a counseling tool, that 20% of patients will have some type of side effect, some worse than others. And again, antimicrobial resistance really affects all areas of medicine. This is partly why we like to do infectious disease and stewardship. We get to interact with a whole bunch of different people. But to that point, antibiotic use is something we all share, and therefore we all share the consequences of antimicrobial resistance. So, things like joint surgery, whenever a joint is replaced, folks get antimicrobial prophylaxis before that procedure. If that doesn't work as well, then there's going to be more joint infections. Or getting patients through transplants, stem cell, organ transplant, rely on being able to manage those opportunistic infections. Same with getting through chemo, getting through childbirth, whether that's cesarean, sections or vaginal deliveries. obviously any area, and there's obviously infinite amount of medicine, all depend on having effective, safe antibiotics. So that, you can imagine how this gets, expensive and causes morbidity and mortality when this gets out of control. So transition to potentially happier notes. To try and help address this, obviously there's many things that need to be done. Stewardship is just one tool. And really stewardship is supposed to be, folks with dedicated time and money basically to try and address this. Organized programs, really about optimizing patients. So getting patients on the right drug at the right time, really. And that goes into dose optimization, optimal duration, again, along with choosing the right drug if needed in the right group. So these are the types of things we're trying to address, both inpatients and as outpatients. Our program specifically has been up and running for almost 10 years now. I think we have, here's our crew. So there's about 8 of us, give or take, on any given day to varying degrees. Many of you may know our colleague, Dr. Kent. She's in the midst of retirement. And then Dr. Davis has a small part of his time dedicated to stewardship amongst many other things. But really the folks on the ground that do most of the work, Maureen in Eastern Zone, Val here in Central Zone, Jason in Northern, Stephen in Western Zone, really this is about it. And so our mandate is really just inpatients. On any given day, about 30% of our inpatients are on a systemic antibiotic. So it's a lot. And, the pretty small crew here to deal with that many prescriptions. So we have to really pick our interventions carefully, many of which aren't successful, but we try obviously to plan them. If they're not successful, figure out why and then revamp them. So we'll be highlighting some of our interventions. Kind of at a higher level, what we try and do is a lot of audit and feedback. So in real time, assessing antibiotic prescriptions and feeding back to prescribers about optimization. This is fairly resource intense, as you can imagine. And given our human resource complement, we only can do so much. So we try and pick areas and cycle through different areas where we can be of most use. Certainly getting OPOR will be valuable because even just generating a inpatient list of certain antibiotics like piperacillin, tazobactam is a laborious process in and of itself right now. So, we will have better tools coming, thankfully, that will be valuable. Again, this is just for inpatients, not even getting to the outpatient where, 90% of prescriptions are being used. But that's another challenge. We, optimize our formulary. We look at guidance around antibiotics, and we'll highlight some of that. Generate antibiograms every 2 years, which we'll highlight, and then a myriad of QI, QA projects, and really rely on partnerships because we are a small program, rely on those partnerships to help develop successful interventions, which I think we'll highlight today. And we should mention there is a pan-Canadian action plan. Many of you will know about this to address AMR. There is a Nova Scotian version of this, which some of you certainly are probably aware of or involved in. And really, there's kind of the big pillars are surveillance, research, stewardship, and infection prevention and control. So, using those 4 pillars to try and tackle those scary numbers we were talking about at the beginning. So just wanted to highlight that. Nova Scotia, really, that's been led by Dr. Strang and others. So yeah, that is, you'll hear more and more of that, hopefully. So this is just a screenshot of our website. The library services have been fantastic about, putting all our information on there. We put all our guidance on there. Again, the antibiograms, which we'll show in a sec, education videos. We do have a patient-friendly website now, which one of our patient reps has really helped a lot with. So it's a pretty good place to find anything. If you're looking for stewardship, you can just Google Nova Scotia Health Stewardship. This will come up. And we put all our materials there, our quarterly reports, everything goes there, and available on the internet, so accessible anywhere. And I think our patient-friendly website, oh, we'll come back to that. Our handbook chapters are there. These are screenshots. So this content is also in our First Line app, which we'll show in a few minutes. But these are meant to be 2 to 3 pages max, decent snapshots about how to manage certain syndromes. So we've shown some examples like cellulitis and animal bites there. Our antibiograms, again, we update these every few years. So this is our local resistance data. Have to be interpreted a little bit carefully, but can be very valuable. One, to show some, high-level trends in resistance, but two, also to help guide practitioners on empiric antibiotic choices. So we'll show an example here, I think. Yeah, so this is so this would be gram-positive isolates. We try and use the regional data as much as possible, but there are pretty strict criteria. Like you need a certain amount of bacteria and whatnot to develop these so that it's usable. So sometimes, we'll certainly have an Eastern Zone one based mainly on, the Sydney Labs data. But sometimes that data comes out as Central Zone just because we see more isolates. All that to say is, for example, Staph aureus here. I think I can, I'll get too fancy here. Yeah, no, I won't. So anyway, the Staph aureus here on top, in that 1 year testing period, 2023, about 420 isolates, and you can see how many were sensitive to the different antibiotics. So you can kind of gather that, cloxacillin was 78%. So that would basically be your MSSA. Let's see here. Fecalis, for example, 99% of the time, amoxicillin or ampicillin would work. Streptococcus pneumonia, amoxicillin, 99%. So for instance, that's why we really use amoxicillin as our main oral agent for Streptococcus pneumonia or community-acquired pneumonia. So it can be quite useful that way. We're going to show some gram-negatives on the next slide. I'm going to erase my smudges here, sorry. Fancy. So here, gram-negatives. This is very valuable. So for example, Pseudomonas here. Nothing's looking too hot when you look across as far as being green. Tobramycin, but tobramycin's a fairly toxic agent. But even things like meropenem, only 84% of the time sensitive. Piptase only 76% of the time. So, these are things we worry about because there aren't great options for bacteria like this. All that to say is this is available on our website. It certainly can be useful to reference from time to time. Our patient-friendly website is available there. So this has, again, patient info around a variety of ID topics that you might find useful to direct patients to. And then our First Line app. So this has been a huge undertaking, really developed during the pandemic around COVID. And then obviously we've expanded since then. The IWK led the way with this across the country. So basically most of the hospitals in the country are on First Line. It's free for end users. You just download the app. It's on all the hospital desktops. You just have to toggle between the different hospitals. So it's a bit of an annoyance as it stands, going between IWK and Nova Scotia Health, but it's the way it is for now. But this houses all our guidelines, has all that antibiogram information in here under each of the different pathogens. Like you can look up E. coli and see how much we're resistant, and then all of our antimicrobial information. So, you can go in there and see, any side effects from tobramycin that you may be worried about or whatever. But there's lots of good information in there. And we try and work on that a fair bit, updating it. We do most of the updating ourselves.
Dr. Bonnar, would you mind if I pop in with a couple of questions that have come up?
Oh, sure.
Question one, do you collect data on outpatient community testing or just inpatient?
Community testing, I assume, like bacterial resistance, I assume, slash antimicrobial use. So despite there being the DIS, there is no real-time reporting of antimicrobial use as it stands in Nova Scotia. Working on that, Dr. Emily Black, one of the pharmacy researchers, has a grant in to develop a dashboard. So you can go to BC and look up antimicrobial use in the community, and they have a lovely dashboard that gets pretty granular. We do not have that, but that's the goal. Because we can't, it's hard to address things in the community when we don't have good information. So to help guide interventions, we really need that as a stepping stone. Working on it, not there yet, hopefully within the next 1 to 2 years. Resistance, we have a little bit of data. Those antibiograms, some of those are, we do break it down inpatient versus outpatient. So there is some data there.
Thank you. And the second question, do medical schools across Canada teach future physicians about their prescribing practices and their impact on MDROs like MRSA and VRE? Are we trending in the right direction regarding physician acceptance of AMS programs in Nova Scotia and across Canada?
Yeah, it's a good question. A bit complicated, of course. The medical school curriculum, there is teaching. I do a little bit of it as well. There's a lot of on-the-job training, as I'm sure you can imagine, in like certainly Med 3, Med 4, and not all trainees come through ID. So we do you know, as much as we can. A lot of that is catching them on their rotations, introducing them to first line, talking about these concepts. Certainly, you know, stewardship is becoming more and more accepted, definitely. Because a lot of the time we're not trying to police antibiotics, we're trying to optimize outcomes for their patients, right? So it depends, you know, that's the angle you take, and that is truly what we want to do. So I should highlight, though, that physicians are only the tip of the iceberg, right? We need nursing on board, pharmacy on board, patients, families, dentistry. We need all areas on board, and that's where things get tricky too, is, you know, curriculums in nursing, for example, or pharmacy. How can that be optimized? There is a dedicated stewardship curriculum in pharmacy led by Dr. Black and others. So that, you know, they're probably leading the way, I would say, the pharmacy crew nationally.
Thank you. And one comment from my colleague here at the IWK who does our Med 3 orientations is that she always mentions first line to them when she does their IPAC orientation. So thank you. That's all the questions. Yes.
Excellent. All right. We'll see what we have coming up next year. Yeah. So to the community point, we try to do as much as we can. The main initiative has been academic detailing. So DAL has a great academic detailing service, and we collaborated with them 2016 or so to update the outpatient guidance. And really, we just revamped those. That academic detailing is happening now, and we so that document is available on DAL Academic Detailing website, and all that information is in first line. So we've really, and Emma certainly, and others have led the way on this, is getting that information out there. And we've really seen good uptake of community first line use. Lots of work to do, but a good starting point. And these are some of the, you know, infographics that we've used in our communication. So just briefly, one example of how this can look is if you have a patient in the community, sore throat, kind of this late teenager, has some lymph nodes, no cough, and then some what we call erythema and exudate on the tonsils. So red, angry, white stuff coming out of their tonsils. You can go into first line, you can click on under guidelines, and it should be under the pharyngitis, I would think. I think Emma has it all sorted here. Yep, respiratory tract. We can go to acute pharyngitis, and we can get some little bit of information there. But we have this assessment, and you can click whatever the patient has. They have 3 of the 4, so we can click those. Yeah, and we're in good shape. We can put in their age, and then this basically calculates the center score. So this, instead of looking up a table, we know score is 3. The guidance is to do a throat swab or point of care testing. And if that's positive, then treat for strep throat. You can click on how do I do that? And under management, antibiotic treatment for group A strep, all there. Now it tells us to use some penicillin for 10 days. That does the trick. Now there is an IPAC tab for first line, not something I know much about, although I know that exists, and that Horizon Health in New Brunswick have used that. So that might be something worth chatting about in the future. Again, I'm not sure what the funding would be like for that, but certainly something to think about. And feel free, I would say, to go to Horizon tab, explore that a little bit, and see what you think. And just come back to Nova Scotia Health for the other guidance. I often get stuck in New York guidance or something, but I'm going to hand it over to Emma. She's going to highlight a few initiatives that we've been involved in. Thank you.
Awesome. Thank you so much, Paul. So yeah, first line, I try to promote it as much as I can. If you don't already have it on your phones, easy enough to Google Nova Scotia Health First Line, and you'll come up with a link where you can just download it directly and keep it quite literally in your back pocket. But we're going to switch gears just a little bit now and move on to just describing a couple of initiatives that our team members have been involved with that actually turned out to be pretty neat sort of intersections of antimicrobial stewardship and IPAC work. So I'll start here by describing the influenza outbreak antiviral management pilot that I was directly involved with. So this pilot would have taken place just over the last respiratory season, so 2024-2025 flu season. This was in Central Zone in the inpatient setting, so any inpatient unit that had an influenza outbreak declared. And this pilot, it was a collaboration between our local IPAC leadership and frontline team members and members of the Nova Scotia Health Influenza Treatment Team, who are a group of pharmacists that work closely with an on-call physician. And their work is really one of the streams of the emerging and re-emerging infections network therapeutics teams. So the whole goal of the collaboration was to facilitate timely and appropriate antiviral therapy at the declaration of an influenza outbreak. So this would be both appropriate treatment for influenza with antivirals, as well as prophylaxis when indicated. So very commonly, a prescription for antiviral prophylaxis would look like this. So oseltamivir, or brand name is Tamiflu, 75 milligrams orally once a day. And this is a drug that requires some tinkering for renal impairment. So sometimes the dose could look a little bit different. So our general workflow looked like this. So at the time an influenza outbreak was declared, there was very, very close communication between the IPAC physician, our local infection control practitioner for the particular unit, as well as the influenza treatment team pharmacist, who often was myself. And essentially, containment measures, they were of course led by the ICP themselves in collaboration with the unit, while the influenza treatment team pharmacist would ensure that antiviral therapy in concordance with the IPAC physician sort of strategy was implemented for patients. So for example, a prophylaxis strategy could be used that would just give antiviral prophylaxis to non-symptomatic patients that were likely to be direct exposures to an influenza positive patient, or there could be scenarios where unit-wide prophylaxis would be indicated. Now, every day there would be very intentional reassessment. I've just called it daily reassessment here. But basically, in other words, it was sometimes a meeting of the minds with the ICP, the unit's manager, the influenza treatment team pharmacist, frontline staff, clinical nurse educator, or other sort of nursing resources as needed, just to openly communicate about what's happening. You know, do you have any new symptomatic patients identified? Are there any new influenza tests pending? Are there any prospective, say, patient discharges or transfers that we should get on top of? Just in order to be proactive about any follow-up that was required. And that would just continue, of course, until the outbreak was declared formally over. And just to speak a little bit more to the role of the influenza treatment team pharmacist. So anyone involved in this team, they were independently prescribing antivirals for influenza, either at treatment doses or prophylaxis doses. And sometimes this could include a switch from prophylactic dosing to treatment dosing in the case that a patient did go on to become symptomatic or test PCR positive for influenza. They take care of antiviral dosage adjustment if, say, renal function was fluctuating. And they're pretty well situated to follow up on patients, say, transferred off an outbreak unit. And I will say, just having close collaboration with the ICPs were just so helpful. I remember the very first influenza outbreak that took place. I was feeling pretty scattered, and it was Leanne O'Shea over on at the Halifax Infirmary. She was super helpful with regards to sort of tracking where patients had been moved. So the flu team would provide patient education when needed, staff education, and then in some cases, there would be an indication for antiviral therapy when a patient was sent home during an active outbreak, and the influenza treatment team pharmacist would help facilitate that supply. And I guess I'll mention too that I guess like a main benefit or a major benefit of having the influenza treatment team involved was that they could be pretty quickly mobilized directly to the unit and just focus on that one task of antiviral prescribing appropriately according to renal function, and just offload that responsibility for the clinical team who have a million other things to take care of at any given time. So we did collect some more granular sort of metrics and information on what we did over the course of the pilot. So in the end, there were 10 influenza outbreaks where we had that IPAC influenza treatment team pharmacy partnership. In terms of patients assessed for antiviral therapy, that clocked in at 296 patients by the influenza treatment team and resulted in 281 oseltamivir or Tamiflu prescriptions, the majority of those being prophylaxis. And we did try to keep track of the total number of patients per outbreak unit who were prescribed prophylaxis. And of course, that it varied quite a bit depending on, well, of course, the size of the unit or the prophylaxis strategy that was implemented, as well as turnover. So there were some units with heavy turnover this past year where that higher end of the range would have been most accurate. One thing that I think anecdotally had been mentioned is that initiating the antiviral practice can be challenging sometimes, just based on human resources. It is a fairly cumbersome task, and we were just sort of happy that with this partnership, we were able to initiate same-day initiation of antivirals in, I believe it was every single outbreak that we were involved in. So next, I'll move on to a second initiative. This is a pretty neat one that the AMS team led a couple years ago, involving the rapid PCR detection of MRSA in blood. And this we did end up publishing in the Microbiology Spectrum Journal a couple years back. So as we know, Staph aureus bloodstream infection is a serious infection associated with high morbidity and mortality. And it requires specific investigations. It requires source control appropriately and appropriate antibiotic therapy in order to manage it well and safely. So optimal therapy for Staph aureus bloodstream infection when it's a methicillin-sensitive isolate or MSSA, as Paul mentioned before, would be something like cefazolin or an anti-staphylococcal penicillin like cloxacillin. But often up front for empiric therapy, before you know the sensitivity of the isolate, vancomycin would be used in order to cover for the chance that it could be MRSA. Now, unfortunately, there is some evidence to suggest that vancomycin upfront as an agent for a methicillin-sensitive Staph aureus bloodstream infection actually is an inferior agent and is associated with poorer patient outcomes, including potentially mortality. Now, there is a commercially available test. It's a molecular test produced by GeneXpert that can rapidly identify Staph aureus and whether or not it's a methicillin-resistant strain directly from the blood by detecting a particular gene. So it's the MEK-A gene that codes for this methicillin resistance. The test itself, I'd say it takes just over an hour to run. I think about 5 minutes to get the specimen prepared, and then about an hour once it is running with the GeneXpert machine. So it's a really very, very efficient way to identify sensitivities and much quicker than traditional lab culture and sensitivity processes. So I think when we looked back at central zone practices when we were completing this project, on average from the time of Staph aureus identification to sensitivities being known was around 30 hours. So a lot of potential to quicken this process. So by implementing this GeneXpert test and identifying the sensitivity sooner, we thought there's real potential to reduce the time it would take to actually intervene and get patients on optimal antibiotic therapy. So the primary objective of our project was to determine the impact of implementing GeneXpert molecular testing coupled with an AMS intervention on the time to optimal antibiotic therapy in patients with Staph aureus bacteremia. We looked at a number of secondary outcomes as well. So kind of quantified the time to appropriate therapy, looked at length of hospital stay, mortality, et cetera. So this was a single center cohort study at the QE2 here in Halifax, and it involved a two-step intervention starting at the time that Staph aureus had been identified in a blood culture by our microlab, just using their traditional standard lab procedures. So once Staph aureus had been identified in a blood sample, then a microlab technician would give our team a call, and then that would sort of initiate this process for implementing the full two-step intervention. First step being performing the GeneXpert molecular testing to determine that, whether we're dealing with MRSA or not. And the second step being phoning the treating physician, the care team, to communicate these results. Hey, you don't actually have MRSA in the case of this particular patient, so it would be totally appropriate to change your antibiotic therapy at this point in time. And would also provide advice on, say, timing of follow-up blood cultures, the need for an ID consult, and just be there to answer any questions. So we did prospectively collect patients to perform this two-step initiative on. It was in early 2020. We also identified a similar cohort of historical patients from the same hospital, and then looked back to compare the patients in terms of their treatment courses, their outcomes, and some demographics. And in the end, it was a pretty small study. We included 56 patients total, 29 in the intervention group, 27 in the control group. And I'll just remind you, it was happening in early 2020. So it was a pretty significant point in time, pandemic-wise, and there were lots of competing interests happening at the same time. But when looking at the primary outcome of time to optimal antibiotic therapy, this did occur more quickly in the GeneXperts or stewardship intervention group that's highlighted in red here. So that occurred at a median of 38 hours from the time of first blood culture draw to the time of being on optimal antibiotics, compared with just over 50 hours historically. So it was a statistically significant improvement in that time to optimal therapy. I won't spend too much time on secondary outcomes. Interestingly, we did end up finding a statistically significant reduced length of hospital stay in our intervention group, but just given the observational nature of this study, there were likely many factors at play contributing to that outcome. So to conclude, implementing the GeneXpert molecular testing with the AMS communication for patients with Staph aureus bloodstream infection did reduce the time to optimal antimicrobial therapy, and was, in our case, reduced with a reduced length of hospital stay. And really, we feel that we could implement this more robustly across the province, and would expect the intervention to contribute to treatment success overall and potentially improve survival. Currently, the gene expert testing has continued in the central zone, but we'd love to see the expansion elsewhere in the province as possible, especially in some of the more rural sites where, cultures would be sent away to a different regional micro lab, and that would contribute to even greater lengths of time that a patient would be potentially on less than optimal therapy. And with that, over to you, Paul.
That's great. Thanks so much. We just have one last initiative to highlight, and then we'll have some time for questions. So this is a screenshot of Dr. Dominic DeWard's work. So she is a cardiovascular surgeon who did her master's project around QI and implementing Staph aureus decolonization in the setting of open heart surgery. So this came about a few years ago now, I think before the pandemic, when they were reviewing, surgical site infection rates, NSQIP data, all the rest. And Dr. Hirsch, along with some of the IPAC crew here, were interested in this. And we weren't sure how we were going to implement it, but Dr. Hirsch said he had a plan, and the plan was basically to get Dr. DeWard's project on this, and she did an amazing job. So she did all this work, and really, really impressive, and basically just highlighting that here. But the WHO surgical site infection guideline really does highlight that decolonizing patients who are Staph aureus colonized, that can be MSSA or MRSA, is quite effective at reducing surgical site infections, particularly for those requiring open heart surgery and also those requiring hardware placement, particularly hip, knee, and spinal hardware placement. This project, of course, was only focused on cardiovascular surgery. And again, Staph aureus is targeted because that is the main culprit for such infections. Certainly the severe infections. And these infections, these sternal infections are pretty horrible. Morbidity, mortality, long antibiotics, often need repeat surgery, vacuum dressings, VON care. So these go on and on for months and months and months. And so that's why these have gained attention. And so the plan was to try and implement this here, where we've never been able to do this before. And that's not unique to our health system. While this is a recommendation from WHO, many hospitals in Canada have a hard time doing this. This is a brief timeline. Basically started in 2022 and took at least a good year or so to get everything rolling and smoothed out. It's required many PDSA cycles. So this went from basically no way of no systematic process to swabbing a patient, getting a lab result. Where does that lab result go? For those who are positive, who follows up on that? Does the decolonization? Where did that material come from? And then making sure patients actually do it before surgery. So huge project. Obviously, all these things seem simple, but once you get to the nitty gritty, can be challenging. So involved many different interested groups: the lab, IPAC, nursing, other physicians, cardiology, CV surgeons, everyone. And I must say, and before I forget, all these projects we've highlighted have really relied on other people to be interested to generate, funds to help to offer their time. So we really are grateful for many, many people involved in these projects. So the plan here, basically what happens is swab, usually a nasal swab, or was a nasal swab, and then had a process in the lab to check for both or either MSSA or MRSA, and then having that communicated to someone. Only positive patients getting mupirocin 2% ointment twice a day in a chlorhexidine body wash for 5 days before the surgery, ideally. both for inpatients and outpatients. And really, again, there are many PDSA cycles to try and smooth this out as much as possible. And this is some of the data. That paper highlights much more, but over that 1 year period, I mean, these are pretty impressive numbers, right? Like over almost 800 patients, really good screening, over 90%, which is very impressive. So I think that speaks to all the planning that went into it and having folks engaged up front to get this going. Getting the decolonization step is a bit of a challenge, as you can imagine. A little bit easier for outpatients, of course, about 78% received it, and that improved over the 6 months. I should say over the year, compared to the first 6 months to the second 6 months, improved. And improved as well for inpatients. This has continued to improve after the study period because this project continues. There's lots of issues, obviously, with inpatients. Some of it is patients get whisked to surgery quickly, or some of that communication around the positive result. What does the positive result mean? Who does the decolonization? All that type of thing. But again, really speaks to the collaborative nature and having a dedicated research person or QI person really for this project, speaks to what can happen. And really, again, the main success of that project is that it's still going on, despite Dr. DeWard being, kind of stepped away from the project, doing her medical training as a surgeon. It's continuing. So that sustainability that we often lose in QI projects has been maintained. So I think we've highlighted antimicrobial resistance as a problem requiring multifactorial responses, including stewardship and IPAC. We have some local resources available and highlighted first-line app on our website, probably areas to optimize those with IPAC. And then just highlight a few exemplary examples of our collaborations. And again, we want to thank everyone for attending today, and thank you to all our collaborators on these projects.
Thank
so
you
happy
both.
to answer the questions. Sorry.
Oh, no, that's okay. I was going to thank you both. Oh, yes, let's
Perfect.
go, Jays.
I didn't know that's going to get snuck in there.
Last minute.
Emma's huge.
We approve. We approve.
Listening.
Thank you both so much. I think that your initial slides of the projection for 2050 were terrifying to everybody attending right now. And while your work focuses on inpatients, those inpatients get discharged and the impacts filter through our community. So if we can prevent antimicrobial resistance in our inpatients, it impacts all of our healthcare settings across the board. So we'll open the floor up for any questions. They can pop them in the chat. We'll give people a second. Lots of amazing initiatives, great resources, fantastic. There is one question that just came in. Is there any AMS work being done in long-term care?
So we certainly don't have any dedicated resources as far as human resources. There have been some point prevalence surveys. I think Tammy McDonald and others have led those. So, there are some surveillance that's happening on antimicrobial use in long-term care. We've tried to implement some long-term guidance into the recent academic detailing guideline. But undoubtedly, yeah, once you get outside of acute care, yeah, there's so much work to do, and certainly long-term care would be one area to try and dedicate more resources to.
One more question. Are you planning to continue to collect data for the influenza outbreak project?
Oh, that's a great question. I think ideally, yes. We are at a point where we're trying to figure out what the next steps are for the pilot. So what will this look like moving into the next flu season? Will it expand beyond just central zone? It's all a little bit unclear. So once the details of that are all sorted out, we plan to send out some wide communication and keep everyone in the know of the potential for collaboration there.
That particular initiative was very interesting to me, having been through some influenza outbreaks on large inpatient units elsewhere where that was not established, and the Tamiflu treatment and prophylaxis was very challenging to navigate for everybody. So to have a team coming at it, huge bonus.
Yeah, agreed. Just simplifies things a lot when it can be quite a tedious task. Yeah.
Yeah, when you especially when you have multiple care providers on the same floor, that coordination can be very onerous.
Absolutely.
We have another question. Do you know if there is any environmental sampling for multi-drug resistant organisms, similar to how water testing was done for COVID? Like, is that wastewater, Michelle? Is that?
Yeah, I'm just wondering, is there anything that can be done to like monitor, I guess the amount of, organisms that we would have that would be multi-drug resistant in our communities? Is that, and I don't even know if this is an option. That's kind of where my brain was going with that question.
Yeah, it's a good question. There's certainly nothing too active happening, I don't think, in those. Because I could be wrong though. Certainly, folks look at that though as a similar to COVID, as a signal, I guess, of trends. Sometimes hard to interpret some of that data for sure, and what that means. One thing, and I should have highlighted this, but in that in our action plan, certainly incorporating agriculture, at least, and animal health is a huge part of that, and that's a whole nother universe. But they've done very interesting things and have had good success around prescribing in agriculture and companion animals, for example. So it's been interesting interacting with them, but we haven't come across too much of the environmental sampling yet, recognizing that we know that antibiotics end up in the environment and can have a profound effect as well, as long with measuring AMR in environmental samples.
We have another comment. I just want to say I've been an ICP since 2012, and these numbers continue to be terrifying. I see lots of initiatives, not seeing great changes, unfortunately. That's my experience. I do support long-term care, and there are similar initiatives, and again, not great changes happening with antibiotic use, but thank you for a great presentation. And then just more thank yous coming in. So I think in the absence of any other questions, we will probably let you guys have your Friday back.